This is a trial with a drug called dapagliflozin, an SGLT2 inhibitor. And the trial we're looking at 17,160 patients, out of which nearly 60% only had multiple risk factor and didn't have established cardiovascular disease, with a relatively very good renal function. The mean was 85. And in those patients, does SGLT2 can prevent cardiovascular events and can prevent deterioration in kidney function over time. Well, these days, first we have shown our data on the elderly. And very surprisingly, even people at the age of 80, 85, we had more than 1,000 people older than 75. They did very well with the drug. The safety was similar to younger patients. So it is a very safe drug to give. And when you look at efficacy, it gave the same efficacy in the very old as it did in younger patients. This is one. The other one was our renal data. We progressed with our renal data. We have demonstrated the strong effect of dapagliflozin to prevent both deterioration in kidney function and deterioration with micro to macroalbuminuria. And the effect was more also on cardio-renal and also on renal specific end stage. I think it should make a big effect in clinical practice. This is a very safe drug, easy to give, hardly you have side effects, and on the other hand, this drug reduces insulin resistance, improves beta cell function, reduce weight, reduce blood pressure, and if anything, reduce the risk for hypoglycemia. So this is a very, very safe and effective drug that was demonstrated to reduce progression in renal function tests and reduce the risk to develop heart failure even in patients who do not have a history of heart failure or who have near normal or normal kidney function. For me, this means that I would give it as a first drug therapy together with metformin to nearly every diabetic patient above the age of 60. The European Cardiology Society came with a very good guideline, but I have two criticisms. One, they are a little bit complicated. Guidelines are being done for family physicians, general practitioners who have to face 50 or 60 guidelines of different diseases. So you have to make it very simple and straightforward. It's not like that. The other thing is that they recommend SGLT2 or GLP-1 as first-line therapy in patients like those we had in DECLARE. But they ignore metformin. And I think we should start and treat patients today with combination therapy, metformin plus SGLT2. And the reason is that we don't only want to prevent cardio-renal events, we also want to cure diabetes, or at least to reverse diabetes. So if we start with combination therapy in patients who have A1C 7, for example, we can normalize his blood glucose, we can postpone his diabetes for many years, and we know now that if you are not well controlled on the first year of diagnosis, your risk for microvascular and macrovascular complication after 10 years are much, much higher. So now we have a safe drug, an effective drug that can affect the patient at the moment that they are being diagnosed. And to my mind, it will take several years until people will get it to the mind, but this is going to be the future treatment. Combination therapy of metformin and SGLT2. Well, today I think many of the cardiologists for sure, nephrologists for sure, are concentrated on the organ. So they say if you have established cardiovascular disease, heart failure, high risk to heart failure, we now made a new score to know who is at a high risk for heart failure. If you have these people, you should start and give them SGLT2. Okay? This is the renal people say, if you have eGFR less than 60, if you have microalbuminuria, if you have anything that suggests kidney disease, start SGLT2. Family physician and even endocrinologists and diabetologists are more cautious. And I think that diabetologists and even family physicians should be the leader for the treatment of this drug because it's so simple, it's so relatively safe, and it's so effective. And family physicians are those who've seen 90 or more than this, 90% of the diabetic population.